Hello friends, I am Dr. SWANAND S Pathak, Professor and Head Department of Pharmacology, JNMC Savangi. The topic of today's discussion is cancer chemotherapy. The topic is important practically as well as from examination point of view. This is our purpose statement. What we want after going through the topic is we should be able to classify anti-cancer drugs, explain the mechanism of action and describe the clinical profiles of the drugs. These are some of the learning objectives. Define cancer, enlist etiological factors for cancers, classify the anti-cancer drugs, describe clinical profile of the cytotoxic drugs, describe the clinical profiles of antimetabolites and discuss the role of monoclonal antibodies in the cancer. Now coming to introduction, what exactly is cancer? It is an abnormal, unwanted multiplication of cells. The cells go on multiplying as if they have forgotten to die, and this abnormal multiplication of cells leads to cancer. It's a disease of cell characterized by some of the characteristics are uncontrolled proliferations. The cells go on proliferating uncontrollably. And what is this? There is de-differentiation, that is anaplasia. Let us try to concentrate on this particular word, anaplasia. What it is a de-differentiation. Generally, when the cells multiply, there is a differentiation and some cells function as one manner, in some cells function as another manner. But there is de-differentiation. We will not be able to differentiate among the cells, and that is what is anaplasia. Then invasiveness. The cells, cancer cells, they have the property of invasiveness and metastasis, that is spread to the other organs. Now, what are common etiological factors? Though there are many etiological factors, these are some of the common factors which we have undertaken. It may be due to virus, Epstein-Barr virus, hepatitis B virus, environmental or occupational hazards, diet and its habits. Even genetic factor is well-known factor for development of the cancers. And finally, the drugs like immunosuppressants. Though there are a number of drugs which can cause the cancer, this is one of the groups that we have taken. What is the basic mechanism involved for development of the cancer? It is first activation of the proto-oncogenes. Proto-oncogenes are nothing but some of the genes in our body which promote the formation of cancer. These are BCL2 and RAS genes, which activation of these proto-oncogenes, and on the other hand, inactivation of tumor suppressor genes. At the same time, our body has the tumor suppressor genes, those genes which suppress the formation of the tumor, and this is P53, that is inactivation of the tumor suppressor genes. Both of these come together to form the cancerous cell growth. There are two basic types of cancers. One is benign and other is malignant. All these are the prerequisites to know what are the drugs for the treatment of cancer. Benign cancers, they have slow growth, while malignant they have fast. Benign resemble normal cells, while malignant do not. Benign tumors are localized, while malignant tumors are invasive and metastatic. Benign tumors are not that harmful, but malignant tumors are harmful if left untreated, and they might cause the death of the person if the tumors are malignant. What is the basic thing required to know the mechanism of actions, or as such the drugs which are used for the treatment of cancer, is this cell cycle. Let us concentrate on this cell cycle from this G0 phase. G0 phase is a resting phase. The cell is not dividing and resting. The cell then enters the G1 phase, that is the cellular contents excluding the chromosomes are duplicated. Other cellular organelles, these are duplicated except the chromosomes. Now the cell moves to the S phase. S stands for synthesis. What happens? Each of the 46 chromosomes, that is in humans, is duplicated by the cells. S moves into G2 phase, that is cell double checks as if everything is correct. The cell double checks the duplicated chromosomes for error, making any needed repairs, and that is the G2 phase. And from G2 phase it enters the mitosis phase and the two cells are formed. Why cell cycle is important? Because what we know, the cancer is a rapidly multiplication of the cells. If we know the cell cycle, we know where the cell cycle should be arrested, because we want to arrest this rapidly multiplication of the cells with the help of the drugs. Now coming to the core of this chapter, presently available anti-cancer drugs can be divided mainly into two types. Drugs acting directly on the cells and drugs acting on the hormonal milieu. This milieu is nothing but environment. It's another word, that is the drugs altering the hormonal milieu, and the first is the drug acting directly on the cells. Let us see one by one. Now coming to the drugs acting directly on the cells. These are further divided into cytotoxic drugs. As the name suggests, cytotoxic. These are the drugs which are toxic to the cells. Which cells? The cancer cells. And what it does, it affects the rapidly multiplying cells, limits the synthesis of nucleic acid and their precursors. And what is important is this third part, that is, so affects normal fast multiplying cells also. What these drugs do, they act on the rapidly multiplying cells. But these drugs are not able to differentiate which are the cancerous cells and which are the normal cells in the body. So along with affecting the rapidly multiplying cancerous cells, it will affect the normal cells also, causing the toxicities. Toxicities and all, we will discuss it a bit later. Now coming to the next, 1A out of this is alkylating agent. It induces the alkylyl group in the nucleophilic moieties in DNA and RNA. Why alkylating? Because it introduces this alkyl group. What happens by introducing of this alkyl group? The function of the DNA and RNA is hampered, and that's why the cell cycle is hampered. So causes cross-linking of the strands of DNA, that is what we do not require. We have one drug under this alkylating agent, nitrogen mustard, cyclophosphamide and ifosfamide. The other drugs which we have is ethylamine, we have thiotepa, which is used for breast cancer. Nitrosoureas, we have carmustine, lomustine, which is used for CNS tumors as well as the melanomas. And triazine, dacarbazine, which is used for the islet cell tumors of pancreas. Now this is a very specific drug, dacarbazine, which is used for the islet cell tumors of the pancreas. Further, we have another group of drugs called anti-metabolites. These inhibit the metabolism of what? These drugs bear the structural resemblance to naturally occurring constituents like purines and pyrimidines, and competitively inhibit the utilization of normal substances. So these are anti-metabolites which inhibit the metabolism of purines and pyrimidines, the building block. And further, we have another drug called as folate antagonist, that is methotrexate. It antagonizes the folate synthesis. It is used in choriocarcinoma, breast carcinoma and acute lymphoid leukemia. Then we have another drug called as purine antagonist. These antagonize the purines. We have 6-mercaptopurine and thiogonine for the treatment of acute myeloid leukemia and chronic myeloid leukemia. And then we have the pyrimidine antagonist, 5-fluorouracil, used for the carcinoma of lung and the carcinoma of breast. What we have done is we have taken some of the very important drugs under this group, though each group may have 10 to 15 drugs, but we have not included all 10 or 15 drugs, but only important drugs which are being shown here, which are used very commonly. Coming to next, antibiotics. Antibiotics, as we know, are the substances which are obtained from the microorganisms and which are used to inhibit the other types of microorganisms. So these are the substances used or obtained from microorganisms. And now they function as the anti-cancer drugs. Get intercalated between the specific base pairs and interfere with template functions. They will interfere with the base pairs, adenine, guanine, cytosine, thymine, and they will interfere in this particular intercalated between the specific base pairs, and they will interfere with the multiplications of the cells. What are the drugs inside there? We have bleomycin, which are used for the testicular carcinomas. HL stands for Hodgkin's lymphoma, NHL stands for non-Hodgkin's lymphoma. And actinomycin D we use in the case of Wilms tumor. A very important thing, actinomycin D, is specifically used for the Wilms tumor. Doxorubicin, daunorubicin, these are used again for the acute myeloid leukemia. What are these? These are the antibiotics. Further, we have the vinca alkaloids. These are the drugs obtained from the vinca rosea plants. That is the plant called as sadafuli in Marathi, and that is vincristine, and used for acute lymphoid leukemia, while minblastine is used for Hodgkin's lymphoma and Kaposi's sarcoma. In the group of taxanes, we have paclitaxel, which is used for the breast carcinoma and ovarian carcinoma. Number of drugs which are being specifically being designed for the treatment of breast carcinoma, because the incidence of breast carcinoma is quite high and it is rapidly increasing. The enzymes, we have L-asparginase, an enzyme which can be used as an anti-cancer for the treatment of acute lymphoid leukemias. Now further, there is this concept of monoclonal antibodies. We had one of the specific learning objective as to know regarding the monoclonal antibodies, what is the function of these monoclonal antibodies. Whatever we have seen previously, these are the drugs which will act on the rapidly multiplying cell, they will inhibit the multiplication, but these drugs cannot differentiate between the normal body cells as well as the abnormal cells. In the body also there are rapidly growing cells like the hairs, like the skin cells, so they will not be able to differentiate, and that is the reason for their toxicity. So what monoclonal antibodies are supposed to do? They are supposed to act on the specific receptors which are present specifically on the tumor cells, and so they will inhibit only the tumor cells and not inhibit the normal cells as such. Which are the drugs which are there? Let us see. The drugs is rituximab, indication chronic lymphoid leukemia, cetuximab, colorectal carcinoma, trastuzumab, that is in the case of breast carcinoma. So this particular concept is rapidly growing of developing the monoclonal antibodies for the specific cancer cells. There are some miscellaneous groups as well. We have hydroxyureas in the for the treatment of chronic myeloid leukemia. We have cisplatin, which acts analogously to alkylating agents. Alkylating agents we already seen. It is used for the treatment of osteosarcoma and testicular carcinoma. While in case of procarbazine, methylates DNA and inhibits RNA, DNA and protein synthesis in Hodgkin's lymphoma and myeloid tumors. And then thalidomide, it inhibits angiogenesis and metastasis. It is used in the case of melanoma. We all know that thalidomide is a drug which was in disrepute because it caused the phacomelia as one of the adverse effects, and it was banned drug throughout. But for what matter this particular thalidomide was used when it was found that there is phacomelia? It was used for the morning sickness. But see how the same drug has come in the market with a different indication, that is for the treatment of the melanoma. So here we can see that the same drug which was first considered as very toxic and was banned has come into market with another indication, an important indication for the treatment of the melanomas. Now coming to the next, this we have finished one group, that is directly acting on the cells. And now these are the indirectly acting drugs altering the hormonal milieu. Milieu is nothing but a jargon for the environment, right? So the drugs which alter the hormonal environment, these are the following drugs. Which are these? These are glucocorticoids like prednisolone, decrease cytokine release, decrease the tissue and promote the cell cycle arrest and induce the cell death. And because of this, what we want is decrease the cell cycle or arrest the cell cycle and induce the cell death. Estrogens, these are used for breast carcinoma, prostate carcinoma. These carcinomas are highly dependent on the hormones for their growth. Then we have selective estrogen receptor modulators, SERMs. These are tamoxifen, one of the very important drugs which is very commonly used for the treatment of breast carcinoma. This is tamoxifen. And then we have selected estrogen down regulators. We have the drug called as fulvestrant, which is used for the treatment of breast carcinoma. Now both these drugs, these are modulating the estrogen receptors. Let the estrogen act, but let us modulate the estrogen receptors in such a way that the growth of the carcinomatous cells is inhibited. Then we have anti-androgen. A very important groups of all these three drugs. Anti-androgens, we have flutamide used for prostate carcinoma. Again 5-alpha reductase inhibitors, finasteride, again prostate carcinoma. And gonadotropin releasing hormone analogs, nafarelin, again for prostate carcinoma. If you see carefully, what all the three drugs are used, all the three groups in fact are used for the treatment of the prostate carcinoma. Because prostate carcinoma is another carcinoma which is very strongly dependent on the hormones for their growth or for their multiplication. Finally, we have something called as the gene therapy. What is gene therapy? Manipulations of genes. Ultimately, what is cancer? It is something wrong which when happens in the genes, that is called as the cancer. So if we change the genes themselves, then we will be able to control the cancer. But it is in infancy. The whole gene therapy is in the infancy. But what is the indication of use, or what is the use of this gene therapy for now? It is causes debulking of tumors. That is, larger tumors are reduced or palliation, there is a smaller size is achieved, and then this smaller tumor is removed, because it is easier surgically to remove the smaller tumors rather than the larger, and this is what the gene therapy achieves, but it is in the infancy. Now coming back to one of the very important slides here, again coming to the cell cycle. We have already discussed regarding the G0 phase, regarding G1 synthetic phase S, G2, M phase, etc. There are certain drugs which are non-specifically will act on all these cycles, or all these stages in the cycles. These are called as phase non-specific drugs. Which are these? These are alkylating agents, nitrosoureas, anti-tumor antibodies, procarbazine, cisplatin, and dacarbazine. All these drugs will act on the whole of this cycle irrespective of the phases and will inhibit the cycle. But there are cell cycle specific drugs also. Like the S cycle specific drugs are 6-mercaptopurine, methotrexate, cytosine arabinose, and hydroxyurea. These are the drugs which are S specific on cell cycles, while M mitosis cycle stage specific are vincristine, vinblastine, lactin. We have seen that vincristine and vinblastine, these are the drugs obtained from the Vinca rosea plant, and these are the M cycle specific. Let it be specific or non-specific, the function that is being served by these drugs is to inhibit these cell cycle. Now let us see some of the common regimens. What do you mean by regimes? Regimes, it is a combination of drugs. As we know, in case of tuberculosis, we have number of drugs which are being combined and given for a particular duration of time. Similarly, in anti-cancer drugs are combined. Why the drugs are combined in the case of anti-cancer therapy? They are combined because first, we want to decrease the dose of each drug. Secondly, we want that there should be the efficacy of the drug of the regime should improve, because each of the drug will act on a different way and the combined effect will be increased. Thirdly, we want that when we decrease the total number of dose for each drug, obviously the adverse effects will also come down. So by combining the drug, we are increasing the efficacy, we are decreasing the individual dose, as well as we are decreasing the toxicity of the drugs. Now let us see what are the common regimes here. Let us concentrate on that. Some of the common regimes I have tried to put here. There are a number of common regimes which are there, at least 20 to 25 which I had come across, but these are three important things that we have tabulated. First is MOPP regimes. What drugs are used? MOPP, all this stands for the drugs. Meclorithamine, then we have vincristine, also called as oncovin, that's why O, procarbazine and prednisolone. And the disease for which this is used is Hodgkin's lymphoma, very popular type of regime for the treatment of Hodgkin's lymphoma. Then we have ELF protocol. These are just for the examples that we are taking. E stands for etoposide, then leucovorin and 5-fluorouracil. This is used for the carcinoma stomach. VAMP regime, that is vincristine, amphotericin, that is methotrexate, 6-mercaptopurine and prednisolone, which is used for acute leukemias. So these are just example, that is to sensitize you that like tuberculosis, we have the regimes for the treatment of the cancers. Now coming to the toxicity. Now remember that these anti-cancer drugs are one of the most toxic drugs that we have with us. If you go and see in the wards that whenever this anti-cancer chemotherapy is started, many a times the condition of the patient deteriorates very fast because of the adverse reactions that are occurring out of these drugs. Because of the thing that we have seen, that the drugs are not able to differentiate between the cancerous cells as well as the normal cells. So they affect the normal cells. You will see that there is loss of hair, there is a patches which are developed on the skins and all this. So these are very toxic drugs, and sometimes the patient dies of the toxicity rather than the cancer itself. So what are these generalized toxicities? Like bone marrow, lymphoreticular tissue, oral cavity, GIT, gonads, fetus, carcinogenicity. See, the drugs themselves are used for the treatment of cancer and they are themselves causing the responsibility for the causation of cancer and hyperuricemia. Why? All these, if you see, right from gonads, fetus, oral cavity, lymphoreticular, bone marrow, these are rapidly multiplying cells in our body and the toxicity is caused due to this. Now coming to the specific toxicity by the drugs, like peripheral neuritis, it is caused by vincristine and it is also caused by paclitaxel. These are characteristics. Nephrotoxicity by cisplatin, ifosfamide and methotrexate. Hemorrhagic cystitis, that is cyclophosphamide. Very important. Hemorrhagic cystitis is an adverse effect of cyclophosphamide, but hepatotoxicity is caused by asparginase and cytarabine. Cardiotoxicity is important feature of doxorubicin, daunorubicin. Pulmonary toxicity by busulfan and bleomycin. Infertility, most of the alkylating agents, they cause infertility, and tumor lysis syndrome due to the release of phosphate. Toxicity amelioration. What do you mean by amelioration? How we decrease the toxicity? There are various ways available with us to decrease the toxicities of these drugs. Let it be specific toxicity or non-specific toxicity. These are the drugs which are given along with the regimes to decrease the toxicity of those individual drugs. What is most important, let us see it here. Folinic acid permits the use of methotrexate more than 100 folds. So we have seen that folinic acid can be given and must be given along with the methotrexate to decrease its toxicity. Now coming to cyclophosphamide, we have seen that hemorrhagic cystitis is an important adverse effect of cyclophosphamide. The drug which is administered is Mesna. Mesna is the drug which is administered for the treatment of cyclophosphamide induced hemorrhagic cystitis. Further, another important drug, ondansetron. Ondansetron is a specific drug used for the chemotherapy induced vomiting, because if you see the patient who has undergone chemotherapy, the patient has severe vomitings and the patient has to be relieved from that particular vomiting, and we have specific drug, not any drug, but a specific drug, ondansetron, for cytotoxic drug induced vomiting. Then in the case of allopurinol alkalization, plenty of fluids for hyperuricemia that is being advised. IV bisphosphonates for hypercalcemia, that is what also can be given. Now, so to summarize, we have come to the end of this particular presentation. What we have done is we have just sensitized you for the treatment of chemotherapy of cancer. What do you mean by chemotherapy of cancer? Why the cell cycle is important? What are the drugs which are cell cycle specific? What are the drugs which are cell cycle non-specific? What do you mean by regimes? What are the mechanism of actions of the drugs? What are the generalized toxicities? What are the specific toxicities? And what to be done for ameliorating or decreasing these toxicities? So to summarize, cancer is an unwanted multiplication of cells. There are two types, malignant and benign. Genetic mutations are also there. Anti-cancer drugs as act to stop multiplication of cells or by killing the cells and altering the hormonal milieu or the environment. So these are some of the bibliographies from which we have taken this particular information, and thank you very much.